I'm an immunologist by training. I was actually trained at SATVI, and I spent actually 8 years at SATVI as a graduate student, first as a master's student, then upgraded to a PhD student. And during that time, I enjoyed doing research, but I felt that I actually needed to connect more with people who actually go through or are exposed to TB. And I informally got involved with AWOSA, and as I progressed in my talk, it was first started as an informal collaboration between researchers in the institute and eventually became an NPO, which established in 2020. So AWOSA is a public engagement NPO that's focused on youth advocacy, science communication, and skills development. Our aim is to coalesce biomedicine of diseases with social impact. And we do this by working with predominantly high school learners, and the learners are participants in our workshops and also active partners. We hope to facilitate access to accurate information about health. Originally, it was focused on TB, but when the COVID-19 pandemic, this has evolved more into TB, HIV, and COVID-19. We also hope to ignite frank conversations around health and also highlighting issues associated with stigma. And primarily, we use storytelling and documentaries as a way to represent people's lived experiences with health and disease. And in the process, we also develop capacity. And as the presentation goes, I'll talk about the different capacity development activities we're involved in. So our long-term goals are to encourage positive health-seeking behavior, engender trust, and decrease stigma. And we hope to do this by sharing more accurate information about health in general, and also highlighting the biomedical research that happens locally. We were incubated within the Institute of Infectious Diseases and Molecular Medicine at the University of Cape Town. And from 2013 to 2019, we ran informal and very distinct projects. And in 2020, we became an independent NPO. So a brief about our actual inception. So in 2013, one of our co-founders, Anastasia Koch, was a biomedical TB researcher, specifically a PhD student. And she felt that even though she knew a lot about TB and she was actively in the lab researching TB, she felt some form of disconnect between the work she was doing and the communities that are affected by this. Unfortunately, within her social circles, one of her friends was Ed Young, who's a conceptual and visual artist, and she was keen on potentially showcasing the research we do by recording biomedical researchers at the IDM and then showing these recordings at different schools. And as Ed Young is a conceptual visual artist, he was like, no, this is way too boring. Why don't we actually contribute to capacity building and expose learners to biomedical research? Then they develop their own documentaries. So this was meant to be a once-off project where learners were recruited from Ikamva Youth in Kailisha. And it started off with a group of about 13 learners. They were brought into the IDM, taught about the different biomedical research that occurs within the institute, and given the opportunity to create a documentary highlighting their lived experiences with TB. Based on this pilot film in 2013, Anastasia Koch and Ed Young were able to secure funding to have more long-term projects that started in 2014. And these enrolled from 2014 to 2019, about 85 learners, high school learners between the ages of 14 and 21, from grades 9 to 11. And over the 6 years we functioned, we would have an annual film screening, which would also work as a recruitment to expose learners to the different work we do and also highlight the work that the learners create during the workshops. And as time progressed, the work we did actually evolved. We're involved with the Sexualities Project with the WITS Institute of Social and Economic Research in 2018, where a few learners that were involved in the learner docs decided to create a documentary about the lives of young lesbians in Kailicha, and this was documented at the Sexualities Project at WITS in Joburg. During the process of creating documentaries, we also like to highlight local music, and we thought that it would be a really great idea for musicians, drug-resistant TB survivors, and the MSF to work together to highlight lived experiences of drug-resistant TB survivors and translate the lived experiences into artistic form, be it poetry and music. And as we continued doing the workshops over 6 years, we also thought it would be an opportunity to actually take part in engaged scholarship. And we recruited an anthropologist to conduct a doctoral research from 2016. And in 2018, we facilitated annual honors public engagement courses. And from 2020 onwards, we were hoping that we could actually expand our reach of learners and have more face-to-face workshops at schools in Kailicha, where the feeder schools that feed into the Kampa Youth Program. But unfortunately, due to COVID and lockdown restrictions, we weren't able to do that. So like I said, in 2020, we became an independent NPO, and this was primarily via funding from the Wellcome Trust organization. And we were so excited to actually expand our projects and have more workshops in 2020 going forward. But as you know, the COVID-19 pandemic hit, and that required us to evaluate and rethink what our main projects were. So as of 2022, our small group, which I'm going to highlight in the next video, in the next slide, is kind of divided into 6 different arms within EOSA. So we have a science communication arm in EOSA that aims to share accurate information about health and also explain the biomedical interventions that lead to health policy. So this is primarily via creation of animations, which is shared on the social media, as well as in local newspapers for people to read. For example, people who don't have access to social media. Our science communication content is also translated into different languages, and including sharing content on our socials and newspaper content in Kailicha. We also share content via collaborators in Botswana as well, and some of our animations and videos are translated into Setswana. We also started creating documentaries that highlighted people's lived experiences with COVID in 2022. So these are very different from the documentaries the high school learners did, and this was facilitated mostly by the work of Samuel Flans and Alpha Fipaza. And from 2020 to 2021, we created about 10 different documentaries that highlighted people's lived experiences, including the forced evictions that happened in Kailicha in the middle of 2020. We also facilitate workshops, which is something I'm more involved in. And I'll discuss the workshops in more detail later during this presentation. And like I said, we do take part in scholarship, engaged scholarship around public engagement via training doctoral students, doing the honors course, and also publishing our work in scientific journals. We also help expand the reach of local musicians within Kailicha by helping create music videos. And we also conduct monitoring and evaluation work to see what the impact of our work is in terms of long and short-term impact, what the different learners that were involved in our workshops are doing currently, how their involvement in the workshops has contributed to their health-seeking behavior and their understanding of health in general, and also to see whether our reach in terms of the content we create expands beyond high school learners and is also well known within the Kailicha community. Like I said, our team is quite small. We are about 9 people. And I think what's a great thing about our team is that it's both scientists, artists, visual artists, animators, and also future educators. And some of our team are actual alumni of the different workshops. For example, Zondikazi Montiani and Alpha Fibaza were took part in the workshops in 2014 and 2015, and now they're active members of the AWOSA organization. Samo Flans joined AWOSA initially as a musician to provide music for the documentaries, and during his time at AWOSA, he's actually been trained to become one of the lead he's the junior creative director at AWOSA, so he leads a lot of the documentaries that we make at our organization. So just to focus a bit on one of our activities, which is the science workshops. So on a usual calendar, so that's between 2014 and 2019, our workshops programs would start around April, which would focus more on screening the content that the previous learners have made, and would also use this as a screening and as well as a recruitment drive. So the learners would talk about their their experiences taking part in the workshops, and also with the hope of it to encourage other high school learners to apply for the for the workshops. So the workshops are not merit-based, but it's more interest-based, and we often ask learners to conceptualize a documentary or a story that they would like to showcase during the workshops. And the actual science workshops happen every Saturday between May and July. And the main focus of the workshops is to expose learners to biomedical research. So we first start off with a session about what biomedical research is, highlighting accurate information about TB. So even though a lot of us know about TB and a lot of us within the community know about TB, there's a lot of misinformation about the causes of TB. So if you would ask someone, for example, they'll think that smoking, poor diet, or dust are the causes of TB and not actually the bacteria, which is Mycobacterium tuberculosis. We also give learners the opportunity to do lab work. So for example, we have a TB drug discovery session where learners actually see what it means when someone says that a bacteria is drug resistant, and it grows even in the presence of being exposed to rifampicin and isoniazid. We also expose them to TB vaccinology, and this is where SATVI would come in. And we talk to them about how vaccines are developed, how vaccines are tested, and also highlight the different clinical trials that have happened within South Africa, specifically trials that have happened at SATVI. Then we also give them an opportunity to take part in like a mock clinical trial. So we try to make this very fun. And what we do is that we give learners Diet Coke or regular Coke and try to see how that impacts their ability to answer math sums. And at the end of this, we give the learners an actual opportunity to design their own research project. So from 2014 to 2018, they'll just like design a project in an hour and create a quick proposal. But in 2019, we changed this to give learners the actual opportunity to design a project that they can actually work in the lab. So for example, they'll create a project to see like which part would you expect to find the most bacteria? And to their surprise, they realize that they actually see more bacteria on their phone compared to like in the toilet, because the toilet is cleaned regularly. Then at the end of the science workshops and during the July school holidays, they have more hands-on training on the media documentary making arm of our flagship core project. So like I said, the high school learners create documentaries, so they're given the opportunity to actually work with very advanced cameras. They're trained on how to shoot videos, how to conduct interviews, the importance of ethics and requesting consent. They're also trained on how to edit these documentaries. So all the documentaries that we showcase that are created by the learners are actually edited by them. So they conceptualize the stories and they edit their stories. And like I said, previous learners become future trainers. So this is Alpha. He was a learner in 2014. And from 2018 onwards, he actually trained learners how to create documentaries. So like I said, at the end of the following year, we do 2 to 3 screenings, and we're hoping that we could have 2 to 3 screenings annually via the NRF public engagement drives we would have at different schools, but unfortunately COVID hit. So last year we had a pilot project in Masiphumelele. So this is at the Desmond Tutu Health Foundation in Masi, and opposite the Desmond Tutu Health Foundation, there's actually Masiphumelele High School. And what we did is we facilitated a much shorter version of the workshop. And this workshop occurred over 7 days. So in 7 days, we recruited 9 high school learners, were given the opportunity to learn about biomedical research, but also have very intense training on how to create documentaries. And to our surprise, because we were a bit anxious about whether we would actually have products done at the end of 7 days, the 9 high school learners created 3 documentaries around 3 different themes. One of them was about highlighting HIV and TB stigma. The other documentary was highlighting people's lived experiences in one of the fires that happened at the end of 2019. And the other one was about highlighting gender-based violence. So what we'll do going forward is have our normal flagship projects that happen at UCT, which are more staggered over 3 to 4 months. And then would have our intensive workshops run through Masiphumelele and the Desmond Tutu Health Foundation. So I'm just going to show a short documentary that was created last year, hopefully to play. Yes. Okay, so you can just let me know if you hear the sound.
Sometimes you realize in this ulwazi lwami nge-TB apha endlini umyeni wami wayenayo i-TB wayitya i-treatment eMasiphumelele ekliniki but zange ancedakale ngodefaulta yena ukuba engafuni uyitya i-treatment eMasiphumelele. So mna nkosikazi wakhe ndisiya kuyomthathela i-treatment Masiphumelele, ndize nayo endlini angafuni ukuyitya. Ndiyithathe i-treatment yakhe ndiyifake epapeni ekutyeni ndimtyise. Abe nomsindo xa asoyiva into yoba ndizifakile ezi pilisi kule treatment.
Okokuqala, it's not a great experience really, akukho mnandi, because ekuqaleni xa abantu bengafundisekanga ngayo baye bacinge into yobana mhlawumbi bangosuleleka, not knowing ihlobo abanokosuleleka ngalo. You feel neglected ngabantu okokuqala, because once you disclose i-status sakho, abantu baye bangafuni ukusondela kuwe, ingakumbi xa bengafundisekanga.
Mna zange ndizive right, but ndaye ndarayithi kuba ndiyazi into yoba xa ndimse encedweni uzoba right.
No, kuzange kube mandi at all, ngoba babengandamkeli. Lahamba ixesha ndade ndafumana uncedo lento yobana ndifumane i-workshop. Ufumana kwami i-workshop ndaye ndababikela kabanzi ukuthi hayi ayosuleli ngoba okanye sinokwabelana ngempahla, okanye benoba secam kwam, okanye sitye ngesitya esinye. Yosulela through sexual intercourse or yosulela through blood.
Ngelaa xesha bendihlala nabantwana bam naye. Abantwana bam ndaye ndabaxelela into yoba utata wenu ufumaniseke enentsholongwane ye-TB. So zange ndibone ngxaki kubo, baye bathi mama utata msekliniki atye i-treatment.
Kona mna zange ndifile kamandi at all, and especially ngexesha ndibaxelela ndazifila isolated, because babefuna uzidistansa kum. imeko ibiyinto yobana bengazi kabanzi nge-HIV. Kha babecinga ukuthi kuba ndinayo maybe ingaba-affecta. Leyo into ndabethakala kakhulu mna into yobana mhlawumbi ndibone abantu sebengafuni ukusondela. Then ndazinika ixesha nam lokubaxelela into yobana ayingeke ibosulele ngokuthi batye sityeni sinye nam okanye sihlambele evaskomini enye. Ingabosulela through into yobana kwabelwane ngesondo okanye ngegazi, i-HIV. Then emveni koko ndaye ndababona into yobana babe noko baye basobuluka. Then emveni koko babuya bandamkela njengomntu ophakathi kwabo.
Andiyazi ke ithiphu uba uyifumene njani because ibe ngumntu obesebenza phandle anethe. Ndacinga uba fanuba ke mna ke yingqele le imfumanayo. Xa ndimsa koogqirha baqala bathi pneumonia. So sizoyiva ngosele egula ke ngoku ekliniki into yoba yi-TB le anayo kuba asakhohlele. I-treatment ewayeyifumene yeye-6 months. Uye wayitya laa 6 months wayigqiba ugqirha wathi urayithi. Yaphinda kwakhe emveni konyaka yamphinda ezoendepha esweleka.
Ubomi bam abutshintshanga kuba ndi-HIV. Ndiyafana nabantu abangenayo because ayibhalwanga kum ndihamba ukuthi I'm HIV. Ndim ozazelayo that I'm HIV, you understand? Hence ke ngoku mna ndingakwazi ukuthi ndingathi ndimahluko kwabanye abantu. Ngoba siyafana singabantu, le nto isegazini.
Umnyanam ke uye wahlala phantsi, akaphangela. Zaninzi into angakwazi uzenza, yaye yamlalisa phantsi.
Qala funeka umntu azamkele yena, azixelele into yobana uma ephila akaphileli mntu bubomi bakhe. Therefore umntu uyakwazi uzixelela uba ndiphila ubomi bam, omnye umntu uphila ubomi bakhe. Therefore iqaleka apho kanye into ukukhathalela impilo yakho, into yobana uzazi into yobana ngexesha eli-right funeka ndenze into ezaba right for myself. So kubantu abangootata out there, the only solution is to tell yourself into yobana ulibale ngabantu abasecaleni kwakho. Wazi what are you looking for, nee-goals zakho in life, because most of the time singabantu abanabantwana to support in life while affected. So utsho ukuthi ke ngoku loo nto, if you stick ekubeni into yobana utya ama-ARVs wakho, you live more longer and you live for the kids and your family around you.
So it's always quite refreshing and seeing the amount of sense of urgency these high school learners have at such a very young age, and also how they feel that it's very important for them as well to highlight the stigma they have and also create content that reduces stigma within their own communities. It's been a very wonderful experience seeing this organization grow and also interacting with learners for the past 8 years. And just seeing how every year, even though we facilitate the same workshop, we always learn from the learners and also find ways to create a better workshop that caters to both our needs and the needs of the learners. So if you'd like to know more about Ewoza, follow our Instagram, Facebook, Vimeo, Twitter, YouTube channels. You can email us. We're always looking for collaborators to work with. And you can also visit us at ewoza.com. Thank you all for listening. And if you're ever interested in reading academic literature about our work, we also publish some academic material in journals. Thank you. I'm not sure if there'll be any questions, but if you have any questions, feel free to ask.
Thank you so much, Dr. Mpande. I see someone has their hand up. You can ask your question if there is one.
Hi, Tilaka. Thank you for that presentation and thank you for the work that you're doing. So, I mean, it goes without saying that obviously the next generation of TB researchers it makes sense for them to be coming out of the very communities that are most affected by TB. I'm just curious whether you're able to monitor any of the learners that have participated in your workshops to see if they have an interest in science, and whether, of course, there are multiple barriers of entry to an institution like UCT, but is there some kind of sort of mentorship program going on? Are you able to track these learners that eventually want to get into science?
Yes. So, like I said, all the learners are part of the INCAMVA youth program, so they do have mentorship from INCAMVA. But independently, we do work with learners who show interest. For example, they email us and say, we want to do more biomedical research. How can we get involved? And we always give one-on-one like mentorship. And we also actively track what our learners do going forward. So our hope is that eventually a lot of the learners become future artists or biomedical researchers, but we also understand just taking part in the workshop contributes to their soft skills. So a lot of the learners report having increased soft skills, specifically having more confidence to speak openly about issues and also have opportunities for public speaking. One of our learners, via her experience in creating media, actually leads like the media wing of her church. So that's also something like really interesting and also great to see, like the capacity is not just about like creating documentaries, but it can also be capacity development for your own passions. So yeah, we actively check what the learners are doing. And from last year, we tend to have 2 workshops to see progress, and that's where we also get feedback on their current health-seeking behaviors.
Thank you so much for that. Are there any other questions from the floor before I carry on? Dr. Mpande, I was just going to say thank you so much again for all the wonderful work that you're doing. And also that documentary was so well done. I would never have thought that a high school student did that. I could have definitely never done something like that in high school. The quality was so good. The content was very relatable. And I think that the work that they're doing is so important, especially in their own communities, because they're from those communities and they understand what's needed. I did have a question though. You said that they make documentaries on different topics. So do they choose those topics themselves, or do you provide them with topics and then they just run with that?
No, all the documentaries that we have ever created are conceptualized by the people who actually create them. So that's something we're very conscious on doing, is that we don't want to give them like themes to cover. So that's why in the recruitment, it's very important that they need to tell us a story they want to share. So like, for example, last year, it just happened out of coincidence that out of the 9 learners, each of them wrote a story around the 3 themes. Then when they came for the workshops, they were like, okay, the 3 of you wanted to talk about TB, HIV. These were your storylines. Discuss amongst yourselves what you're going to do. So we just facilitate the training for education. I mean, in terms of training on how to create the documentaries, the editing, but all the conceptual input and the directing of the documentaries, even finding people to interview is all by the learners. So it's amazing. It's amazing, like even in a 7-day, very intense workshop for like 4 hours a day, that they can create something so amazing, so beautiful, and so like cinematic.
Yes, it definitely is very amazing. And it just goes to show that if given the opportunity and the resources, I'm sure that anybody has the potential to do anything. So then there's lots of untapped potential in all of our communities around South Africa. So it's something to think about as well. But thank you so much for everything. That is a very interesting talk. I really enjoyed it, and I'm sure everyone else did as well. Thank you. So our next speaker will be Dr. Justin Shenje. from the South African TB Vaccine Initiative, so SATVI. And he'll be talking to us about the TB treatment TB treatment studies currently happening at SATVI. So welcome, Dr. Shenje. We are very happy to have you.
Good afternoon, everyone. Yeah, so first of all, just a small correction. I'm just going to talk about TB research in general. Then I will also just add on some of the work that we're doing at SATVI. So let me just pull up my slides. Okay, so if you can let me know once you can see the slides, then we can start.
I can't see anything yet.
Okay. I think it's coming. I think there's a bit of a connectivity problem on my side, but I think it's almost there. Okay, I think it should be showing now.
Yes, they're showing now. Thank you.
Okay, so I just want to let you know upfront that the main objective of this talk is just to advocate for more TB researchers. And I hope to do that by sharing with you the burden of TB in our community, the shortcomings of current treatment strategies, the challenges of TB research, and also the competitive advantage that we have as South Africa when we are conducting TB research. So first of all, I think most all of us are aware that TB is a big problem in South Africa. So according to the South African TB prevalence survey, the South African TB incidence was 737 per 100,000, and this was in 2018. So it hovers around that level, even though over the last 2 years, the number seems to have gone down, but I think it's just because that it has been overshadowed by COVID. So the WHO went on to state that the leading cause of TB, the leading cause of death in South Africa in 2019 was TB, with 58,000 deaths in 2019. So I think when we compare this to the number of people who've died because of COVID, which is estimated to be about 100,000 over these last 2 years, you can see that TB is a major problem, even though it has been overshadowed, especially recently by COVID. And it also estimates that 55% of South Africans have latent TB infection. So what this tells us is that about more than half the population is exposed to TB. So given all these factors, it shows that this is a really urgent issue that needs to be addressed. So coming to the shortcomings of the current treatment strategies. So TB can be broadly classified into drug-sensitive TB and drug-resistant TB. And for drug-sensitive TB, it's a 6-month treatment of mostly 4 drugs. And one of the challenges with this treatment is the issue of adherence. And it's quite a big problem because adherence is linked to efficacy. So what that means is when there's poor adherence, then there's also very low efficacy. And I think Chileka's documentary showed that perfectly well, that this is one of the challenges that we face in the community, that most people are not able to complete their treatment. And the other issue with drug-sensitive TB is the emergence of drug-resistant TB, which is a lot more difficult to treat. And particularly, I think it's also important to note that at the moment, the main test that we use in clinics to diagnose TB is the gene expert, which has the lovely advantage of a quick turnaround time and is able to tell us whether a patient is resistant to rifampicin, the most important drug in our first-line anti-TBs treatment. But often isoniazid monoresistance is often underdiagnosed, and we don't know how huge this problem is and what effect it has on the long-term outcomes of people who are treated with TB. So this is a major concern. Coming to drug-resistant TB, drug-resistant TB is a lot more difficult to treat. Often the treatment requires 12 to 18 months of treatment, an even larger pill burden, which often includes injectable drugs, which can be painful. And despite the duration of treatment being longer and a larger pill burden, the treatment outcomes for drug-resistant TB are much poorer than for drug-sensitive TB. And it also has a lot more complications and a lot more side effects, sorry. So I think I'd also like to emphasize that the current treatment that we have for drug-sensitive TB is over 50 years old. So just to highlight how tragic this is, in the picture, if you look on your left, that's a Toyota Corolla from the late 60s. And on your right is the latest version of the Toyota Corolla. You can see there's been massive advances in technology in virtually all aspects of our life. But when it comes to the treatment of drug-sensitive TB, it has remained the same for over 50 years, which I think is quite tragic. So, coming to the challenges of doing TB research itself. So, the first and most important thing is the diagnostic tools that we have are imperfect. So, our sputum culture has a very long turnaround time, and the sensitivity is also not so great. And these diagnostic tools, their performance is even worse in high-risk populations. For example, in people living with HIV and also in children under the age of 5. So this is of great concern. So whenever we do our research, one of the things we want to do is to be able to measure our outcomes. And if our diagnostic tool is not ideal, then it creates a lot of uncertainty. The other challenge that we have is the issue of TB recurrence. So the major challenge with TB is once someone is treated, even treated successfully for TB, there's a higher risk of recurrence, especially the first year after treatment. And when we're trying to find better treatment regimes, so even if some treatment regimes which have initially have high bactericidal efficacy, some treatment end up having even higher TB recurrence rate, which is counterproductive. So it adds an additional layer of difficulty. So it often means that when you conduct these studies, you have to have a very long follow-up time so that we can actually pick up the long-term treatment outcomes associated with each regime. The other challenge that we have is, for drug-sensitive TB, despite it being so old, it actually has a good efficacy. It has, under strict DOTS conditions, it has an efficacy above 90%. So, unfortunately, in the real world, it's not always possible for us to do effective DOTS. So you find a lot of patients are not able to complete their treatment. And now when you conduct clinical trials, you find that the people on the standard of care do a lot better than they would do when they're in a clinic setting. So this actually makes it very difficult to find treatment regimes which are better than the standard of care under ideal conditions. And lastly, TB is a very complex disease. So the incidence of TBs, it's also affected by many different factors, such as poverty, malnutrition, overcrowding. And often these factors, if the studies are not designed well, might not be able to pick up these factors, and they might actually affect the outcomes. So even though there are a lot of challenges associated with TB research, so as researchers, what we're basically looking for are problems so that we can find solutions to these problems. So that's basically what we do in research. So I'd also like to emphasize that even though there are so many challenges associated with TB research, as South Africa, we have a competitive advantage. So firstly, there's a high incidence of TB in South Africa. And with high incidence of TB, it makes it more feasible to be able to recruit a sufficient number of participants in order to conduct meaningful trials. So with most study, one of the things that we'll often fight with statisticians are sample size estimates. Before you plan and design your study, you have to have a sense of how many participants you need, so that you can find a reasonable difference when you compare your different study arms. And I think I mentioned earlier on that there's a high mortality that's associated with TB. And so the combination of a high incidence and high mortality means that you're more likely to be able to conduct research which has a high impact and is able to lead to policy change or influence policy, and that also means that you're more likely to win awards, which I think all of us would like to at some point. But most important is that in South Africa, there's a great network of experts in the field. This means there are a lot of potential mentors who can get you started on a path as a TB researcher. So, as I mentioned earlier on, TB is a very complex problem. And often when you do your TB treatment research, there are many different fields or areas of research which are important to understand. So, as mentioned before, the challenge of diagnostics. So there's a lot of work going into finding better diagnostic tools. There are challenges when it comes to sputum collection, especially these days of COVID. The major concern of infection control has even been magnified. It's always been there, but it's that much worse these days. So, it would be ideal to be able to find, blood-based markers. And I'm glad to say that SATVI has been involved in pioneering work in transcriptomics, where we have been able to develop a signature that can potentially change the way we diagnose TB. Another area of importance is microbiology. If you're going to fight the enemy, you need to be able to understand the enemy. So TB has a unique, complex immunogenic lipid cell wall, which allows it to evade the host immune system. So gaining a better understanding of how this immunogenic cell wall works and how it contributes to it being a fastidious organism, which has the ability to remain dormant even when a patient is on treatment, it's very important for us to find better treatment regimes. Immunology is also important. We work with a lot of immunologists. Cheleka is one of them. And part of that is we need to understand the complex interaction that leads to granuloma formation. And that helps us understand better why some people get, I mentioned earlier on that about more than half the population of South Africa has latent TB infection, but not everyone gets TB. And often this is because of this complex relationship between the host immunity and the organism itself. So hopefully getting a better understanding of that can help us treat or even prevent TB. There's a lot of work also going on in regards to therapeutic vaccines. Quite a number of vaccines have been shown to have therapeutic benefit. One of the major challenges with TB is TB recurrence, and vaccines such as the H56 vaccines have shown promise in reducing the likelihood of TB recurrence. And another issue is the issue of prophylaxis. As you know, prevention is better than cure. And the current prophylactic strategy that we have is isoniazid prophylaxis. And the duration of isoniazid prophylaxis is very long, also riddled with side effects. And there are a few new prophylactic regimes that are being explored, which are a lot shorter, which are taken once weekly, which can help with adherence, because adherence is always a big issue. And another exciting field is the field of pharmacokinetics. So I'm pleased to say that recently there have been a few new TB drugs that have been discovered. And it's not enough to just find new drugs. As you know, TB treatment requires multiple drugs. And whenever you combine drugs, we're not sure what then happens. So the drug interactions, it's important to also study how these drugs interact with each other, because sometimes there's a risk that some drugs might inhibit the uptake of others or vice versa. And more so, TB and HIV often occur together, and there's the additional complexity of combining TB treatment with antiretroviral therapy. And lastly, the issue of adherence. You know, with the advent of new technology, with smartphones, with video calling, you know, there's always that question as to how can we improve adherence, especially given that we know that even the old TB treatment regime for drug-sensitive TB is effective as long as we have good adherence. So all these areas are exciting areas of research where potential researchers can focus on. And yeah, and the hope is that when they find their niche, they can make their contribution to TB research. So lastly, in summary, TB is a huge health problem that we face in South Africa, but it also presents a great opportunity to make a difference and to serve our community. So I hope at least some of you are considering a path as a TB researcher. Thank you.
Thank you so much, Dr. Shenje. I especially liked the end of your presentation there, the way you're looking at TB as a positive, as a way for us to make a difference, even though it is a challenge, but it's the reason that it's because we have challenges that we're able to solve them and make differences in the community. So thank you so much for that. That was very informative. And also very inspiring, just listening to the way that you speak about TB. It shows how passionate you are about it. And I think we can all appreciate that because we know how important TB awareness and advocacy is in our setting. So if there's any questions from anyone on the call, you can just raise your hand and you can ask the question now. Or even if it's not a question, even a comment or a compliment, because we love those. Yeah, I just have a question for Dr. Shenje. You said you were speaking about a test, a TB test to do with blood results. I'm not sure if I missed it or not, but how far along is that research? Like instead of the gene expert.
Yeah, so there are a number of immunologists on this call who I saw earlier on who are actively involved with that. But feel free to jump in. So through some of our previous work, there was an epidemiological study that was done several years ago, and quite a number of samples were collected. And this was a group of adolescents who were followed up as part of a TB vaccine study. While the findings of the study were not positive, but one thing that was done during that study is blood was collected, and they looked at which genes, the blood was analyzed to look at which genes were activated in the patients who ended up getting TB. So they ended up devising a transcriptomic signature, which actually is able to not only diagnose, but is also able to predict who are likely to get TB in the future. So it is still in experimental phase. There are quite a number of similar signatures which have been discovered, but there's still a long way to go before this can then be used as a test, a standard of care. I don't know if there are any of the guys who'd also like to add on that.
Yeah, thank you so much. It's good to know that even though you say that there's still a ways to go before you get there, it's good to know that people are thinking in that direction to make diagnostics quicker, because treatment always has a way of being delayed in the healthcare system. So it's inspiring to see that these things are still happening and it's in the works. So thank you so much for that. I'm not sure if someone raised their hand now. Oh, someone did raise their hand. Zandile Kolisi.
Yes, thank you. I'm a second year medic, so I don't really have that much of clinical experience. And probably showing my question, but I would just like to know, since the doctor mentioned that under strict DOTS, drug-sensitive TB was shown to have an efficacy of treatment of more than 90%. I've read articles that were talking about the challenges of implementing DOTS, especially in the setting that we have, and how that might actually be, one of the contributors to adherence and all of that. So I just want to know, is there something that's happening in terms of policy and trying to come up with new treatment strategies besides the DOTS, or are there things being done to make the DOTS, program or strategy a bit more effective?
Yeah, thank you very much. That's a really good question. So you're absolutely right that in an ideal setting, drug-sensitive TB, the first line TB treatment works very well. However, we don't live in a perfect world. For any of us who've ever been on treatment for a prolonged period of time, will understand the challenges of adherence. And it's not that patients are difficult, but it's very difficult to get people to commit to 6 months of treatment, especially if there are side effects along the way. So there is a lot of research into trying to shorten TB treatment regimes. And I'm actually glad to say that as SATVI, we were part of a groundbreaking study, which was published last year, which was able to show that 4-month TB treatment regime, which contained rifapentine instead of rifampicin, and had an moxifloxacin in place of ethambutol, and had an additional moxifloxacin in the continuation phase, was just as effective as the 6 months of TB treatment. So, you know, reducing the duration of treatment by a third, I think, is a phenomenal step. But even with that, I think we still have quite a bit to go. After the findings of these studies, it was published last year, the WHO has issued a report, and hopefully we're going to be seeing guidelines of the TB treatment being, the duration being reduced to 4 months on this new regime. So we're keeping our fingers crossed, and hopefully that could be a small step that we've done to contribute to improving the treatment options that we have. However, there's still a lot more that needs to be done, because 4 months is still a long time, and the adherence issues still remain. So because we do a lot of TB studies and we work under clinical trial conditions, so when you're under clinical trial, the monitoring for participants has to be a lot more stringent, and that means for us, we're held at a higher standard when it comes to DOTS. So we are working on piloting video-aided DOTS, where in our upcoming study, where we will be giving participants, you know, a basic smartphone and data, and we will be doing the DOTS over video, and hopefully this may help to improve DOTS. However, we do understand that in our setting, you know, with load shedding, with crime, risk of theft of cell phones, with poor network, we're not sure how this is going to work. But even if we can actually reduce by 50% the number of people who need to do a home visit and actually visualize them taking their TB medication, I think we can, this can go a long way to improving treatment outcomes in our patients.
Thank you so much, Dr. Shenji. That is also quite interesting to hear all of the interventions you're thinking of implementing. Like you said, there are like lots of challenges to think of as well, but I think they sound quite good, especially the one about the cell phones. It's not without its challenges, but it sounds like it could be something that could work in future. So yeah, thank you for all the insights. So it's very interesting to hear. Are there any other questions from anybody? If not, then we have reached the end of our session. Thank you so much to everybody for attending this evening. Like I said in the beginning, TB awareness and TB research is a very, very important topic, and it's something that weighs it's a big part of the health burden in South Africa. So if we can raise awareness about TB or TB education in even the slightest way, that will make a big difference. So thank you all so much for attending, and thank you especially to our speakers. Unfortunately, if we were in person, you would have gotten a lovely gift. And unfortunately, we are online, so you'll just have to accept our thanks virtually. Thank you so much, though. The things that we learned this evening and the stories that you told us, and the lessons that we've all learned, I'm sure it will stay with us forever. And I'm sure that many people will take it with them into their daily lives and their careers, wherever they are, because it was all quite inspirational. So thank you so much for joining us, and good evening, everyone.
Thank you. Bye.
Thank you.
Thank you. Bye.
Goodbye.
Thank you. Have a great evening.
You too. Bye, everyone.